my family background is that I am from Zob, and I am by caste Mandokhail. And some of the temperament issues which I am having is because my grandfather was a freedom fighter, so he fought against British Army, and in Mandokhail I am Karezai. And then what inspired me was like I saw the sufferings of patients when I was working in medicine department, and in most of the cases I was not able to help them out, in the sense that all the world they are working on prevention, and in Pakistan we are working on the curative model, and I decided that I need to go for the preventive side. So I did my masters in primary healthcare management from Thailand, and then I did second masters in public health from Health Services Academy, Islamabad. So basically I'm a public health specialist, the preventive medicine, which is a new word in Balochistan and in Pakistan, because if you look around the world, all the countries they are working on preventive model. So that was the reason that I decided that I need to opt for a profession where I can help people, that before they are suffered, I can help them and I can help them in preventing them from suffering. So that is why I opted for preventive side. We faced many challenges. First, my family was not allowing me to do masters in public health. They were saying that you need to go for the clinical side and you need to do FCPS or MRCP, because the scope of FCPS in Pakistan is like, or the MRCP is on higher side, while public health was a new thing. They were saying that what is the difference between a public health specialist or a CSP officer? Why don't then you do CSS? Why you wasted your 5 years in medical colleges? So even my father was secretary irrigation and secretary public health. He was not allowing me for public health side, that this is waste of time. And then I convinced him that all the world, and then one of my senior or two of my seniors, one of them Dr. Mustafa is here. So they talked to my father and they told him that public health is the new you can say side, or the brighter side of health, where you can help prevent people suffering from diseases. But the challenges were like, in those days Aga Khan was the only institute, so I was in Thailand, and Thailand I faced a lot of challenges. The language, the food, I struggled a lot adjusting with the environment. The temperature was humid and very hot in Thailand. I was fortunate enough that I was posted as MS Fatima Jinnah. Before Fatima Jinnah, I was posted as Chief Executive Sheikh Zayed Hospital on Saryab Road. I was there for 1 month, but then on the request of teaching faculty in Fatima Jinnah, I was posted by the previous government as MS Fatima Jinnah. That was a simple TB sanatorium, and what we realized that hospital is on huge area. It is almost 33 or 34 acres. So we decided to convert it into a complete chest hospital. In first priority, what we did, we started the complete pulmonology, the chest medicine services, and then we requested the government that we need to have the chest surgery, the thoracic surgery services as well. So we got very good support of 550 million Pakistani rupees for chest surgery, and the doctors and nurses hostel. And the good thing about Fatima Jinnah was the ownership from the healthcare providers there. I started the same thing in Sheikh Zayed, but I was posted out in Fatima Jinnah. What we did, we notified the executive council. That was our internal arrangement, and it was successful in the sense that there were representatives from every department, including paramedics and the pharmacy. And every decision was, everything proposed was discussed in executive council, and through consultation of executive council and then their final decision, I was the one who was implementing it. And if you want to have a successful model of hospitals in public sector, you need to give them autonomy, not only administrative autonomy but the financial autonomy as well. And you need to manage them through boards or through public private partnership, which is a very good successful model, especially for district headquarter hospital. MRF requested me, some of the other organizations, they requested me that I need to be a bound or the bridge between them and health department, that we need to go for the public private partnership at district level as well. But if you want to run the public hospitals in Quetta, the tertiary care hospitals, you need to give them the financial administrative autonomy, as well as you need to run them through boards. Otherwise, with the existing setup, I can say that it is almost impossible to take them to the level which is required. As I mentioned that there are three different levels, primary, secondary and tertiary. For tertiary care, you need to give them the autonomy, as I mentioned, but for primary and secondary, secondary is RFC. You need to devolve the powers to districts. After 18th Amendment, what happened? Unfortunately, some of the powers, they were not devolved from federal to provinces, and then provinces were not able to devolve the powers from Quetta to districts. All the powers are centralized here in Quetta. Quetta is not the only district in Balochistan. So the powers need to be devolved not for health but for the other departments as well. You need to empower them, and then you need to go for the core competencies. You know, the posting and transfers, they need to be made on the competency, and core competencies are compulsory and they are must. Unfortunately, in Balochistan, even in public sector, they are looking at the seniority of officials, that if he is near 60, if he is very senior. But if you look around the world, the selection are basis on the basis of competency. If you look at the topmost companies in the world, the chief executives are the youngsters, and they are selected on the basis of competency than seniority. But before devolving powers, you need to sit here in Quetta, and a consultation is required. That is again a policy matter. We still don't have the health policy. The draft is available, but that is not approved yet from cabinet and from assembly. So first priority need to be health policy need to be approved, and then devolve the powers to districts. That is the solution, I think, as far as I know. Alternative medicine is public health, as I mentioned, and that is the solution. We are poor province and we are poor country, and you know, on curative side you need a lot of resources, but for preventive side you don't need a lot of resources. This is one time investment. You need to spend more on hygiene and sanitation. You know, you cannot get rid of polio with polio drops only. You need to focus on hygiene and sanitation as well. The practices matter a lot. If you don't improve practices, if you don't go for changing the attitudes and behaviors, whatever you do, it is a waste, because behaviors and attitudes will bring the change. And for that, the best thing to do is to go for the public health side. Thailand don't have malaria, they are malaria free. They invested once on public health side, and then they are now malaria free. They are reporting zero malaria except for their border Vietnam and with Vietnam and Laos. Otherwise, Thailand is malaria free. I can quote many examples. Even if you just talk about the maternal mortality is 788 out of 100,000 in Balochistan. Again, you know, we need to spend on public health side more than on curative side. The mother-in-law need to be sensitized. We need to advocate them on antenatal care. We need to improve the nutritional status of women and girls, especially adolescent girls. They are treated as second-class citizens, and whatever is left, first the families are very poor, and then whatever is left at home, that food is provided to the adolescent girls and the reproductive age women. which is aggravating the situation. So we need to spend more money on public health or preventive side. That is the solution. I don't want to claim that I did bring a change, but I was posted in Sheikh Zayed Hospital for 1 month. I was not fortunate enough to spend more time there. I was in Balochistan Institute of Nephrology and Urology for 1 month as chief executive. I did individually what I did. I installed the machinery and equipment which was lying in corridors from last so many years, but that was individual based approach. Now I am working on 3 or 4 proposals. The telemedicine proposal I developed, and now it is on the table of IUPs. Telemedicine can bring revolutionary change in the sense that in our districts where the doctors are not available, through this technology we can provide the services at district level, at BHU level, or at RHC level through this telemedicine. And then I can say that in nutrition, the change is that nutrition was working in pockets. There were 3 different nutrition programs working in Balochistan. We brought them under one umbrella, and they are now working under Nutrition Directorate. And then there were duplication of services. So many people, they were doing different interventions without coordinating with each other. Now we are going for the integrated approach. We are trying to integrate the maternal and child health services, and the concept paper is approved. Now we are working on PC1. That will be revolutionary in the sense that 3 or 4 different programs are working on maternal and child health without interacting with each other and without them on one page. And then I was in MSD for quite some time. What we proposed for MSD was a decentralized model, and then I was posted in DG office, Director General Health Office, and we did suggested reforms, and I am told that they are still working on it. I don't know where is the delay, but it is delayed for reasons. We don't even have the inventory list of the assets of Health Department Balochistan. We don't know that how much HR is in the field and which health facility and where are the gaps. So we developed the checklist, and we will now get the complete report through that checklist where we can find the gaps, at where are the gaps, and then we can accordingly address those gaps. We don't know about the gap of HR, that how much HR is required, like especially the paramedical staff, and how much we are producing. We have the mushroom growth of schools, the paramedical schools in Quetta, and we don't know what is the demand, and against that what supplies we are getting in from those schools. So we have proposals in pipeline, and we are hoping, as far as where I see myself, I think I am still the public health student, and I would like to go for my PhD in next 1 or 2 years, so I can improve myself as a public health student. My experience with MSD was bitter in the sense that that is very centralized model. The procurement is not as per the need of districts or hospitals. They are procuring it in lump sum manner by justifying it that the cost is less if you procure it, but they are not getting the genuine demands of districts, which every districts have their own dynamics, and every districts have their own requirements accordingly. So they are buying it at centralized level in lump sum manner. We propose the decentralized model for MSD. At every district, or at least at divisional level, every division need to sit together, and then they need to compile the requirement, and then the rate contracting need to be in Quetta, the trainings need to be in Quetta, and the coordination need to be in Quetta through this centralized MSD. But the procurement need to be at district or divisional level as per the requirement of districts. But MSD is, there is no mechanism of drug tracking or the equipment tracking. Nobody is knowing like what is the requirement of which district and what equipment is required, and then what is the status of that equipment when it reach that district, either it is installed or not, either it is functional or not, and then there is no mechanism of maintaining those equipments. No resources are allocated for the repair of those equipments. After installing, the MSD or the company is leaving that district, and then nobody is turning back towards that district asking them that what is the status of your machine. So once it is out of order, that thing is left there, and then they are asking for the new machine. And in Balochistan, where we are poor province and we don't have enough resources, if you are following that pathway, it will be difficult to sustain services and to run or manage the public sector hospitals. Well, nutrition program, when I joined, it was nutrition cell in DG office, and then we were getting the partial support from our UN partners. What we did, we brought them under one umbrella, and then our role is coordination, our role is preparing the proposals, our role as nutrition program is to identify the gaps, and we are following a national, at national level we have community management of acute malnutrition, so we need to follow that policy, which is a national policy. In the past we were working in pockets. At in some districts we were providing the MAM services, in other districts we were providing the SAM services, and it was in pockets, and very few districts were getting the nutrition services. Our aim is to ensure that every district of Balochistan is supported by nutrition program, and then through partners we request them for the commodities, the supplies, and the the HR, the training of HR in field, and wherever the gap is, we are trying to get the support from our partners, and we are filling that gap. And then the monitoring as well, we are monitoring the nutrition activities from provincial level, as well as we are we build the capacity of district health officers and their teams. They are also monitoring the nutrition services in districts, but our main role is coordination and developing the proposals.